All right. Okay, so first things first, I'm planning on kind of doing mostly on kind of your treatment, your complications, and as well I have some other stuff here. I think the focus is a lot less on fully understanding the patho of cancer and more about just understanding your general idea of what cancer is, your manifestations, and kind of understanding the treatment. So how radiation, chemo, surgery, all your complications, and then just understanding like your QSEN. So I wrote here some of your best practice and QSEN stuff to keep in mind with an oncology patient. But for now, I guess we can talk about the definition of cancer. And again, it's not, you don't have to know it in such a super detailed form. You're not really going to get questions like define cancer. You're not going to get a question that says cure cancer, write a paragraph. I don't know. Right. So just kind of understand the general idea of it. So what's like a simplified way we can think about cancer? Pretty much. Yeah. Yep. So pretty much growth of cells in an abnormal manner or in the wrong place and or in the wrong area. So we know things such as cells naturally have their own predetermined death. That's the apoptosis. And cells can also have something called like contact inhibition. Basically, if cells are too close together, they'll be like, oh, I don't need to multiply more. The only other thing I would think, just understand, like kind of like a basic contact inhibition. I don't even think you need to know that in really detail. I don't remember. I don't remember a focus being on understanding the whole progress of how answer kind of goes. That's not really the main thing here. Just kind of understand that there is no contact inhibition, meaning that the cells don't know when to stop replicating. Something else I would add in is that there is little to no differentiation, meaning cancer cells are not really specified, specialized. So when you have your cell, and it becomes something like, oh, red blood cell or a lung cell, those cells are differentiated from like a general stem cell, for example. Yeah, so cell inhibition, meaning that if it touches, yeah, kind of basically that. If it can tell that there's too many cells around it, it um it decides that it's gonna stop growing. So kind of it's the process of arresting cell growth when cells come in contact with each other. So they come in contact with each other, so they know, okay, there's no more room, you can stop replicating. But cancer cells don't have this mechanism in mind. So because they lack contact inhibition, so they just keep replicating. I guess I'll specify. So, and cancer cells are not really specialized. So that's what that means in your grading. So in your grading, it was the the more or the worse it is, then the less differentiated it is. So like the high grade for grading tumors and stuff is your undifferentiated, meaning that there is it's behaving kind of like a brand new cell. It's trying to do it all. It doesn't have a specific role. It's just it's almost like becoming independent. it's rebelling and becoming independent, trying to be its own thing. And that's where you get some stuff with cancer, where cancer can start producing, even can start like adhering to its own blood supply and stealing nutrition from the rest of your body, and all of that compounded with the severe growth. That's when you start having issues. Yeah, so little to no differentiation is bad. But again, this is extra information, just trying to have like a quick understanding of that, but it's really not important for what we're doing here. We are more about the management and not and less about the pure patho, less about um all of this stuff here. So let me see if I can find a really good way of just kind of explaining the differentiation on here. If I have something pre-written. Mm-mm-mm. Yeah, so on the French, I guess on the differentiated, kind of like lacking a purpose. Um, I almost said tries to do it all, kind of steals blood supply. So if you do go back and look at the summary of carcinogenesis and all that stuff, that's kind of when it becomes starts trying to spread faster, developing its own blood nourishment supply instead of trying to do a specialized role like every other cell in your body eventually does. But again, that's not the focus. It's just to have a general baseline of what cancer is. So what is important is understanding your gold standard for diagnostics and your manifestations and whatnot. So what is your gold standard for determining cancer or diagnosing cancer? Yeah, it's going to be your biopsy. So there's different types of biopsies, but your biopsy is essentially taking a sample of the cells from a certain place and then analyzing it. So that's something um, that's going to be your gold standard. That's going to be the best way to determine staging and determining disease process and whatnot. So that's your gold standard for that. What are some other things that can be looked at for your cancer? There's some labs, sure. Some labs, and there's says the science. ABCDE. Yeah. For skin cancer, we can have the ABCDE. This is like a generalized cancer section. So for skin cancer, we have the ABCDE. There's a few tumor markers. Yeah, there are some tumor markers as well. I guess I'll kind of be a little bit kind of be basic. So kind of a CBC with differential, CBC with diff, BMPs be involved. So there are specific tumor markers, but right now I'm just kind of trying to be a little bit more general. So there are some that are going to be specific for specific types of cancers, but right now it's just kind of a general idea. Some the other diagnostics here, I'm trying to make sure that we get our stuff done on time. I think we will, though. I think this one's not as long. MRIs, CT scans, ultrasounds. Ultrasound, CT scans can look at some tumor growth. Um, yeah, chest X-ray as well, or just an X-ray in general. All of these can be good for looking at tumors and things, but typically your CT or your MRI are going to be able to see cancer growths that are a bit smaller, while your ultrasound or your X-ray might not be as good for that. Do you know what would be abnormal on the CBC? So again, it depends a lot on the type of cancer that it is, but some other cancers like a leukemia or something will have issues with the white blood cells, but um patients can develop anemia a lot. It can be a lot, kind of bleeding. In general, cancer can cause like some inflammatory effects. So again, the white blood cell count can be something that can be off. Um, Fluid electrolytes can also be off, especially if they're already getting treatment, but um, it's kind of like a basic thing. I think the main thing to really focus in on is that your biopsy is going to be your gold standard, and some of these are things that will be ordered just to see, look at the patient and what's going on. Okay. So this is from there on out, what I really want to focus on, other than this part here, the gold standard, is on pretty much everything else, which is the manifestations, your interventions, your complications. So here I have so we kind of talked about this, but yeah. I have kind of some mnemonics. Um, so I have this one, caution up. I think you guys learned caution. I have an extra two that I like to add on, but can you guys tell me what caution stands for? Yeah, so we have changes in the bowels. So that's again, this is for generalized cancer stuff. So change in the bowels. So maybe someone has like a GI type of cancer going. So change in the bowel movement, change in the bowel or bladder habits, a sore that does not heal. That happens. As someone said, indigestion. Yep. Unexplained anemia. Yeah, so that's actually one of the ones that I have. So there's unusual bleeding here, unusual bleeding or discharge. And this one I associate kind of with like menstruation, for example, can be, or for discharge at least, an unusual bleeding could also be related to that. So menstruation patterns, rather, change in menstruation patterns. Thickening, yes, so thickening or a lump in the breast or elsewhere. So it could be testicular cancer. Oh, it could be yes, an obvious change in cord or a mole. Again, these are all kind of like general things to think about. So what's the N? So we talked about GI. We have basically here with GI, it's kind of made me like yeah, the nagging cough. So that's kind of where some of your lung related cancers can come from. Um, well, so some GI stuff, not being able to heal, so maybe like a skin cancer, unusual bleeding or discharge, change in menstruation patterns, might have some sort of cervical cancer or something. Breast cancer, testicular cancer, more GI stuff, and more skin cancer. And then someone mentioned the anemia. So my U and P, um, I used the U for unexplained weight loss. So weight loss that's not intentional. So people that have cancer a lot of time will be losing a lot of weight. And that kind of has to go related with what we talked about, how cancer cells will over time try to create their own nourishment line and blood supply line. So they'll start stealing nutrition and blood supply from the rest of the body. So that's where some of that weight loss goes from, as well as just general cell damage and then pernicious anemia, the P. So you'll have anemia, deficiency of vitamin B12, and all that other stuff you guys learned about. And I think with Kaylin's session, you guys already talked about this, so you guys should know it. So let's see, what's your skin cancer ones? Yeah, so it's your asymmetry. Yeah, so E kind of could be evolving or elevation as well is what it used to be, and then I think at some point they made it to evolving slash elevation. Yeah, so evolving elevation kind of referring to so evolving kind of referring to just kind of a weird change with it. So yeah, so I have a symmetry, border, the color, the diameter, and the specific diameter. I think one of you even mentioned it already. Well, yeah, greater than 6 millimeters. And evolving or elevation. So with some of your skin cancer, you can have the cells kind of bunch up and it kind of looks like a weird scab kind of thing. Okay. And then let's go over general signs and symptoms of cancer. What can you guys think about? It kind of already kind of goes along with some of the stuff here, but see if we can get other stuff as well. Yeah, fatigue's going to be a really big one. Remember, we have that anemia, and your body's going to be tired from the fact that your body is just not um some of the nutrition, some of that blood flow isn't even going to the right places. It's being used up on the growth of your cancer. You're basically your cancer is basically stealing resources from you in order to grow itself. So yes, so you can have altered GI, so that's where you have that weight loss, anorexia. Keep in mind, anorexia just means loss of appetite. Um, there's different types. So anorexia just means loss of appetite. Anorexia nervosa is the one we think about when we think about anorexia. A lot of the time, that's the mental disorder that you don't want to eat. But anorexia on its own just refers to loss of appetite. Oh, those $320. That'll help. Mhm. And then cachexia is referring to muscle loss, muscle wasting, basically. So what else? So I'm looking for one kind of like a one word that kind of has a lot of things going in on it. Like one word that can, how else do I explain it? One sign and symptom that incorporates a lot of stuff all in once. And that's, I think, going to be your hallmark. Starts with a P. I'm sure there's some pain. Sure there's some pain. They can have brain fog, but I think one word that incorporates three concepts starts with a P, and it's gonna drive a lot of your treatment. Yeah, keep coming all the good stuff here. Can't have brain fog. Brain fogs can also be associated with like chemo as well. Yeah, so exactly. So what is the one word that starts with a P that incorporates, yeah. So pancytopenia. So break it down. Pan meaning all, like Pangea. Cyto meaning cell. Penia meaning deficiency of. Keep that in mind. You'll see this one a lot referenced a lot in this chapter. So pancytopenia, because this is something that's common with pretty much all of the cancers and even something that occurs with the cancer treatment. So this is something that will be um, changing how you treat the patient compared to other people on the floor because they're going to have anemia, they're going to have risk of bleeding, they're going to have risk of infections. So just something to keep in mind. This is probably like your hallmark, really big thing to keep in mind out of that. Okay. All right. So I have one here just kind of like on oncogenesis and staging grading, but again, I don't think it's a big priority. Um, so I'll come back to it if we have time. Otherwise, I'd rather move on. Like aplastic anemia. So aplastic, A meaning without, plas meaning, I believe, formation. So anemia where you just don't create any of the appropriate cells. Hmm. Yeah. So aplastic anemia, a plasm referring to growth. So aplastic means without growth, relating to no growth. Anemia meaning that you are just not creating the right cells. So you will have pancytopenia because you're just not even making them. Okay. And real quick, just kind of breaking down tumors into benign and malignant. Just the understanding that benign is just normal growth at the wrong growth at the wrong place or time. Um, how to say, but with normal function. So a benign tumor is a growth through a normal process. It's just in the wrong place or time, but it's not malignant, meaning it's not cancerous, where it doesn't have, is it a polyp? Benign tumor, hmm,
I think politics is the thing, but I think that's a biopsy.
I'm not really sure on the question personally. I think Kalen just told me probably if someone has a polyp, they probably do like a biopsy just to check. But let me see your question. Give me like the exact difference between them. But polyps are benign. So polyp is kind of like a square and a rectangle. It looks like a polyp. Most polyps are benign. Tumors can be benign or malignant, but most polyps will be benign. Um, the tumor is more generalized. The polyp is more specific, kind of the kind of growth in the mucous membranes specifically. But again, not a priority for now. Because right now, I really just want to focus in on what's probably the most important stuff, which is the radiation, chemo, complications, and then understanding your Q-sense stuff. So honestly, we'll probably go out a little bit early if we have time. Or rather, we'll probably go out a little early because I'm trying to make sure that you guys aren't here all day, but also just when we're hyper focusing on the specific stuff I think is most important, it ends up cutting a lot of the fluff from this chapter. So just kind of knowing cancer is growth. I think that's more than enough here. Okay, so now we have radiation, chemotherapy, and then there's also surgery. So here, the cancer treatment can either be localized or systemic. Between radiation or chemotherapy, which one is localized and which one's systemic? Yeah, so your chemotherapy is going to be systemic. This is going to be the ones where you take medication for them and it's going to affect your whole system. While your radiation, there's two types of radiation, but both of them are going to be more localized, just focused on the part that you have cancer, like where the tumor is or where the growth is, very localized to that area where the radiation is going to hit. Or even with the internal, they can put like a little like radioactive beads, I believe, is what they use for that. Putting it close or inside the tumor to. Can you explain how they differ in attacking the cells? So your chemotherapy is going to be more like medication. Your radiation is quite literally going to be radio waves going in and killing a lot of the how do you say the rapidly dividing cells. And some of your chemo meds, there's like different chemo meds for different things, and they operate in different way. There's some chemo meds that are specific for breast cancer, and they all operate in different ways. So I think your main thing is really just to understand one of them can affect you in a localized manner. The other one affects you in a like kind of systemic, and that they're both overall going to potentially have an effect on your whole system, on your rapidly dividing cells. So that's why people on chemo can have issues with kind of like mouth sores because your their skin in your mouth is really rapidly dividing, so it kind of ends up damaging that tissue and leading to sores in your mouth. Okay. Is there any questions on anything at all so far? No? Okay. I'm gonna add a section just kind of prevention of cancer. Maybe we can put down some risk factors here. Family history is one. Chemical exposure, yeah. Red meats can for like colon cancers and stuff. Definitely smoking. Smoking alcohol. What's your probably like your number one risk factor, like the largest risk factor for developing cancer? Yeah, it's gonna be age. So hopefully everything now, yeah, kind of, huh? Sun, yeah, sun exposure can for sure. Is there a specific age?
Must be fully cooked by final raw peace in mind. And I eat it, so if I get sick tonight.
I don't know if there's a specific age. Well, Khaled said 40 plus. Looking at other resources, I'm seeing that the increases significantly above 50, but 65 or older is where most people get diagnosed. But somewhere around that age. Okay. So back to radiation now. So the main thing I want to know between external and internal radiation is this patient considered radioactive? So with external radiation, is this radiation from outside towards the body? Is this radioactive? Yeah. So that means patient does not require isolation. What about internal? Are they radioactive? Yeah, they have those radioactive seeds and stuff in them. So this patient is radioactive and patient needs reverse isolation. So what's the difference between an reverse isolation and like normal isolation? Yeah, so normally like your contact isolation or whatever, that's actually for your protection. But the reverse isolation is to protect us from them,
Them from us.
or yeah, protect
Them from us.
them from us. Yeah, guess I would say there's split them up. Mm-mm. Similar, yeah, similar idea. Essentially, the patient's gonna have a weakened immune system. Patient's gonna need to protect it from infection and all that stuff. And that kind of goes along with a lot of your QSEN and best practice for safety as well that we'll go over in a little bit. All right. So what's your general signs and symptoms of radiation therapy? Mm-hmm.
Fatigue.
Yeah. So kind of just in the skin, you can have like alopecia. It's kind of your hair though, but yeah. Yeah. Immunosuppression, dry skin, photosensitivity in particular, sensitivity to the radiation area, skin redness, breakdown, altered taste. I'm sure anything else. Let me see. Immunosuppression. Yeah. So that's why we're doing reverse isolate. I'm on some of them. Yeah, fatigue's another really good one. Just kind of the general idea you can get here. It's more localized, so it's very much um focuses kind of like on those. Yeah, you can have some nausea, vomiting changes, anorexia, all that stuff. But a lot of the main things to think about is kind of these two because it's localized to the area where the radiation's taking place in. Okay. They have diarrhea and constipation. Yeah, I believe they can have diarrhea and stuff. Mm-mm-mm. So what are some complications that you can have with radiation? Or like your your biggest one. I guess it also is kind of dependent on where the radiation takes place, but something you really want to think about. Someone has, I guess if someone's got like thyroid cancer and we're doing localized radiation to that area, there's other better ways to affect the thyroid, but putting radiation in the neck area. Yeah, you can have like decreased bone density and stuff, but there's a few. That's the hard part about this one is that it can be doesn't have to be like a little bit more depending on the area that it happens, but in general, I guess if oh wow, yeah, oh wow, yeah, just like dermatitis is good. You can have yeah, I mean, mucositis. Like if it's in the mouth area, then you can have like some of the sores. And then also, if you have radiation going to the neck area, you can have some dysphagia, inflammation, and that can lead to airway problems, neutropenia. That can happen, yeah. This one's a little bit harder to kind of come up with just because it's been more localized. So it depends on where it's happening. But what about the education on this one? Yeah, what we're no people within 6 feet. Yeah, I believe that's yeah. All that stuff is pretty good here. Kind of goes with this. We'll talk about a little bit. I guess we'll talk about this then because it is kind of I kind of just wanted to have like the best practice stuff listed down. It's kind of hard to just ask you guys to know all the 2 cent stuff. So I kind of just wrote it down here. So I guess we'll just go over it. So the education and then for the patients and then also for you is that radioactive patients, it's only going to be with trained personnel. They're going to have their own private room, private bath. We're going to keep the door closed, similar to the neutropenic precautions. There's going to be a sign on the door. We're going to come with like a little dosimeter that's going to show like the level of radiation and stuff happening in the room. We're going to have a lead apron and shield to protect ourselves. Um, and you're going to make sure not to turn your back. Each nurse needs their own dosimeter, even if it's the same patient. Honestly, I don't know the answer to that. Okay. Yeah. Well, seems like everybody agrees with that, so we'll go with that. Pregnancy is discouraged. You want to limit the time in the room, 30 minutes, 6 feet apart. Limit visitors, especially children less under 16 or pregnant women. Don't turn your back on them because your lead apron doesn't cover your back. Okay, so that's interesting. Have your own batch for a specific time frame so they can monitor the dosage. Okay. Don't touch radioactive things with your bare hands. Pretty obvious. Don't expose radiation site to sunlight for up to a year after treatment completion. So again, we're going to make sure that the patients are using sunblock, avoiding sunlight as much as they can, but obviously not to the point where they're just hermiting inside the room. So what is the right time frame when they can go out? I don't know the answer to that. I'm sorry. I think Kaylin went over with it on you guys. Is that right?
Well,
10 to 4? Boyd?
that's what Khalid said. I'm taking the assumption he right.
Is that the time to avoid going out or go?
Yeah, that's your peak time.
Okay. So 10 to 4 would be your the time you want to avoid rather than the time to go out. Alexa says she worked with radiation in an animal hospital and you change batches every 30 days. They send a report back with your radiation exposure dose. Oh, interesting. Really cool. Okay, good to know. Um, I guess while we're here, this also kind of goes with patient education here. Best practice for patient safety. We want to limit the visitors and the healthcare providers that are going in and out of the room. Make sure you wear your proper PPE. You're going to have dedicated supplies in the room, somewhat similar to on some patients. We'll keep like one of the stethoscopes in there. So you can just walk in and then clean the stethoscope and then use it. Everybody has their own private room. You're going to have good hygiene, wear a mask. That's for infection because these patients are going to be at a high risk for infection. Avoiding flower or plants because they can get sick from that. They're at a risk of bleeding because they're pancytopenic. So we're gonna make sure to put ice on trauma areas. Again, risk of bleeding and damaging themselves. So a soft bristle toothbrush or gentle floss. Again monitor for bleeding. Make sure they don't have issues with injuries to their scalp. Remember your proper IB tubing. Don't blow the nose too hard. That's a good call as well. You want to get like a nosebleed. Make sure that everything is clean. So if they do have central lines, which a lot of them will have central lines, if they're going to be, it's more for like chemo, I guess. They will be cleaning the site with chlorhexidine, and this is your basically your education there. So for that, I'm gonna say C. Okay. So now for your chemotherapy, what is your goal and your function of them? Kind of talked about this a little bit. So this is going to be a systemic prevent complication. I guess I meant like what they do rather. Yeah, yeah, no problem. That is definitely something we're going to do though. I guess the main thing I want to keep in mind is how it functions. So your chemotherapy is there to kill, is it there to kill cancer cells specifically? Technically, it's mostly targeting cells that quickly multiply. Yeah. So obviously the intent is to kill the cancer cells, but it's going to very specifically target cells that like quickly. So because of that, you're going to have issues with mouth sores and general hair loss and stuff like that. That's why you have all of that because all of these are things that are quickly multiplying, and it's also systemic, so it's going to start affecting all of this stuff at once. Whereas with your localized, it's going to be depending more on where that radiation is hitting. So you could have hair loss with external or even internal radiation, but it depends on how close to their body it actually is. While chemo is systemic, so you'll have more of this stuff going on. All right, that's pretty much the important stuff with that. else then. Okay. So let's talk about your signs and symptoms um, on someone with chemotherapy. What are some things that they will experience? Definitely nausea, vomiting. That's going to be a common one. So some things like kind of give antiemetics 30 minutes before, like a good idea, because they're going to be very nauseous. Definitely fatigue, definitely mucositis. So, but there's one word that I'm looking for that I want you guys to really think about every time when it comes to cancer and some of your therapies. It's that one word again, pancytopenia, which does in fact incorporate anemia like you mentioned, neutropenia like you mentioned, and then thrombocytopenia. So this is what I want you guys to think about. Instead of memorizing like, oh, it does this and this and that, and this and this and that, just kind of cluster it all down, pancytopenia. And then this is what's going to guide a lot of your interventions. Yeah, they can have some neuropathy, the vomiting, diarrhea, electrolyte imbalances. Yeah, they can get out of hands. Yeah, the chemo fog, another thing. Yeah, weight loss. Because they're gonna be anorexic and they're gonna or anorexic in terms of lack of appetite. They're gonna be you can have malnutrition and stuff. And it's also just kind of associated with cancer. And then your long-term signs and symptoms for it. I don't think this one's not anywhere near as important, I think, as I don't think that it's even really emphasized. So kind of just the cardiovascular, kidney, fine, kind of just basic, but it's not emphasized as much as just understanding your pancytopenia and your considerations. What are some considerations? We kind of already talked about them, but I think it's like pretty important to keep emphasizing it. Yeah, so be careful with infection. You want to avoid getting sick, avoid you want to avoid getting live vaccination. So you want to get vaccinated, but not if they're live vaccine. General safety. What are some live vaccines? Examples of live vaccines? Find out. So MMR, your chickenpox, that's your varicella. I think those are probably going to be the most common ones you'll see. Why not? I think they're more likely to have complications because a live vaccination is going to be like a weakened version of the actual virus, and your body's going to have to do its immune response, but the body's immunocompromised, so they're not going to be as good as someone else in developing natural immunity with the live vaccination. That makes sense. Question that's set to avoid people who recently, yeah, that makes sense. So avoid getting vaccination and avoid those. So again, the idea is basically immune system's worse. So this live vaccination on you will just give you an immune response without really feeling much. But for them, they'll actually get, they'll essentially have that illness to some degree more than someone like you. So they might actually have an actual infection that they're getting vaccinated for because of that. What else are some things to avoid that we kind of talked about before? Kind of a weird one, but yeah, but it makes sense. There's one I'm looking for. Maybe like stuff to room temperature drinks. I think that's because of the mouth pain. So, that I've been sitting for 1 hour. I guess if they've been sitting out, I probably wouldn't want to give them either. That's yeah, I would bacteria. Yeah, probably avoid that. That's a good idea. But yeah, I guess like things to avoid. Yeah, avoid fresh fruit, avoid flowers, and raw meat. Fresh fruits, vegetables. It can have more bacteria kind of on them. The flowers can bring bacteria, and raw meat obviously can have a lot of use for them if they were to get it. Eat raw meat. So another thing to consider is kind of good rinsing of the mouth for the mucositis. So with the rinsing of the mouth, you can do like normal saline or prescribed mouthwash. So I've seen it at the hospital. I've had a cancer patient. I can't remember what the name of the medication was. It was a while ago, but it was like a prescription mouthwash. So you don't want to just give them any mouthwash. It has to be a prescription mouthwash. So if you were asked a question on can a CNA do the mouth rinsing? Can they do the mouth rinsing if it's normal saline? Yeah, so a CNA actually can do the mouth rinsing with normal saline, but what about the mouthwash? Yeah, so with the prescription mouthwash, it'll actually, at least when I had the patient, it showed up either way, but yeah, it'll show up in the order. So for me, it was an order. I had to scan the mouthwash, and obviously the CNA doesn't have the ability to give medication, so it is technically a medication with the mouthwash, but they can do the normal saline. But could an LVN do the mouthwash? A prescription mouthwash? I believe they can. Be fine, yeah, because they can give meds as long as it's not like an IV or stuff. I believe they should be able to. But yeah, this is something that can help them with comfort or even yeah, it's like something you can do to help them with their comfort and stuff. Can help with the pain as well with the mucositis. Because some patients they might not want to eat as well because of the pain from the mouth sores. So they might not be wanting to put food down because of it. I mean, if they're hungry, they might be in pain when they eat. Yeah. So that kind of goes with your general ones here, your soft bristles, which is why I like putting it here for you guys just because it's pretty applicable for everything. And then I think if you guys have the especially this one here, the best practice, I think if you guys have this down, you can understand a lot of the questions you'll be asked. And just watch out for the wording. Make sure that you're reading the question properly. It's not got some weird, tricky wording. Yeah, so this is like a nice comfort method with that. And then surgery is just kind of surgery. I don't think you guys really got much on it. It was pretty much just yes, you can also do surgery to remove tumors and stuff. So we'll just uh, think right now the main focus really that I wanna make sure you guys understand is biopsy is the gold standard. Pancytopenia is a general sign and symptom, both in cancer as well as with your radiation and your chemo. Your chemo is systemic, your radiation is localized. So keep that in mind. You'll have pancytopenia more with your chemo than anything. A lot of your sun symptoms with the radiation is going to be your changes in skin and your photosensitivity is probably another big area to focus on. So understand what you do when someone has that chemo is to put sunscreen on, avoid scented lotions, but keep that area away from the sun if able. Things to uh, definitely really focus on these considerations. So live vaccines, I think, avoiding these things. The mouth rinse is good, and definitely look down at the best practice. This one is good information to know for sure. I think the main ones to focus in is the limit time in the room, the limit of visitors, um, and everything else is kind of maybe a little bit extra, but definitely not bad to know. Understanding like the lead apron and that it's only protecting the front, patients on a private room, all that stuff here. So then the next important thing with cancer outline is going to be their complications. So these are going to be the most common complications you have with the condition. So you guys again don't know you guys aren't like specifically taught as much on sepsis, maybe like a little tiny little bit on it. But what is probably like your hallmark thing with sepsis that you guys learn in 220? That is something that can happen. I wouldn't call it the hallmark part of it, but it can lead to EIC for sure.
Oh, it's not what you.
So I'd probably say like a hallmark lab. How about that?
Oh,
Yeah. So your lactic acid, would that be high, low? What would it be? Yeah, it'd be a high lactic acid lab. So in 240, and in a whole year from now, you guys will go specifically over septic shock. But I think the main thing that's really emphasized here is your high lactic acid. And do we understand why that's the case? You guys remember biology, the Krebs cycle? What are the levels? So I don't want to give you guys different numbers because actually don't think we got numbers in 220. In 240, we got numbers, but I'm not sure what they're going to go off if they're even going to test on the actual numbers rather than just the knowledge of it. But your lactate, yeah, it's related to anaerobic metabolism. Actually, you guys go over lactic acid with general shock as well, but that's another thing that's important. Um, yeah, in 240 they tell us, I believe it's less than two is like acceptable. Acceptable. More than four severe. But I think it depends whether the patient's in a critical state versus like a normal patient. I've gotten multiple different values on it. But more than two makes them want to take the lab again and then keep monitoring you based on all this stuff. And then more than four, it's very likely that you are accepted. You're going to septic shock. But again, that's not necessarily here right now, so we're not going to worry about it. But we're just going to do some of your normal stuff, check for elevated temperature. You will have high heart rate for compensation. So I did see you guys had that one question on hypovolemic shock. So make sure you recognize that your body's going to compensate for your low blood pressure that kind of goes along with shock and give you a high heart rate and high respiration. These are compensatory factors as your body's doing its best. So white blood cell count, yeah, your white blood cell count is part of your thing as well. So you can monitor your white blood cell count and your bands. So that's your immature neutrophils. So if you guys remember that one 212 question that was like shift to the left or something. That's what that was referring to the immature neutrophils. And the higher that the bands are, it's kind of saying it's like an indicator for a worse condition. So how can we treat this? Just kind of a basic outline of how do we treat it. So someone's septic, they have an infection, so we're going to treat them with antibiotics. Um, what else can we do? So I'm sure you guys have had a lot of patients that have infections or something that they do. Gyration. I don't know what that is. Yeah, IV fluids. So if this patient's like in potential risk for shock, we need to give them IV fluids. Oh, gyration's supposed to be hydration. I was like, what? It's like we're spinning them around. Yeah. So antibiotics, IV fluids, and then vasopressors as well. But that's not sure if you guys even went over too much of sepsis other than just knowing it can happen for it, for cancer. But again, it makes sense, right? With your chemotherapy and your radiation, you can become pancytopenic and your cancer pancytopenic. So you will have that neutropenia. So you will have higher risk of infection. So these people can easily become septic. So your hallmark lab is your lactic acid. We're going to make sure we're going to check for the temperature, your compensatory factors, and your low blood pressure. Because remember, sepsis can lead to septic shock, red blood cells as well. And we're going to treat it with infections. So we're going to treat it with antibiotics. I'm sure you guys have had a lot of infection patients. We also give them IV fluids to keep the blood pressure up and vasopressors if it gets really bad. That's the general idea there. So what about DIC? So DIC is something that can come from the sepsis. Your sepsis is basically a huge, your body just has a huge inflammatory response, releases all of the troops out. So if your body's releasing all of your possible reactions, clotting your inflammatory stuff, eventually you have DIC because your body is using up all of your clotting factors stuff. So what would you put as kind of like hallmark stuff of DIC? The labs for that? Yeah, sure. In that one, your hallmark lab would be like your D dimer. Your D dimer would be high, which is signifying that there used to be a clot at some point. Put hallmark physical symptom. There's like two in my brain that I'm kind of thinking about. It kind of goes directly with clotting cascade. So you'll have for labs your platelet count. Your platelet count will be low because it's used up. These PT decrease, yeah. So your PT will be actually probably be more like increase PT because your PT and INR are high. So this is your clotting, how fast you're clotting. So high because it's taking a while. What about your physical symptoms? Someone has DIC, what do you expect to see? Or what do you expect them to be at a high risk of having? Your bleeding is a big one. And there's one more that I'm not sure if you guys go over too well. So kind of makes sense, right? If everything is being used up, that's because there are what? If all of your clotting factors are used up, there must be presence of this or micro or something
Microwave.
or one with C. Micro something with C.
I mean, particular.
Yeah, but you'll have petechiae. It kind of goes along with the bleeding. But bleeding, petechiae, I'll include that. Yeah. Basically bruising, petechiae. This one? Probably not. There we go. See, yeah, it's okay. None of us spelled it right. It's okay. I'm not alone on that. Let's see, what I was looking here was for microclot. So your body's using up all your clotting factors, meaning it's actually doing clots. They're tiny little baby clots, which is why one of your treatments for DIC
Could be.
is heparin drip. Heparin drip. So even though we do think of heparin for it's going to increase your risk of bleeding, and that's what's happening. But it depends on the condition. So we'll either do a heparin drip if clotting is the main issue. We can do a um, fresh frozen plasma, fresh frozen plasma or platelet infusion if bleeding is the issue. And that's vitamin K. Vitamin K definitely can help because we want to prevent them from bleeding out. But yeah, that's kind of the thing with DIC is that you have microclots, but you're also at a huge risk of bleeding. So it's like, are we worried about the clots at the moment? Are we worried about the bleeding at the moment? Kind of have to let one go and obviously treat the cause. I don't think you guys go over too much for these two emergencies, but I just wanted to go over because it's something that will come up in the future. So in the future, you'll see more stuff on DIC, more stuff on sepsis. It's just kind of getting the general idea out of the way. Because I remember in 20 though, I saw like a DIC question on some of these, and one of the things was like, oh, you give heparin. That's kind of interesting. It's kind of like that. It's like I think the question was like, what's the controversial treatment for DIC? So your heparin, even though it's like, oh, they're bleeding, the heparin drip can help with the microclots. So that seems to be the main issue. If you can control the bleeding, then the heparin drip can be given. You might have to do platelet infusion or fresh frozen plasma if you need more clotting factors. And hopefully we can treat the sepsis that's causing it or whatever else is causing it. Going to be the main thing for that. Okay. Is there any questions on what we talked about? Okay. So now, tumor lysis syndrome. Can anyone explain to me what that is? partially in the name, but yeah, it happens when you have your much cancers. Yeah. So exactly. So if you guys remember, when we talked about rhabdomyolysis is the bursting of muscle cells. When your muscle cells are bursting, they release electrolytes, especially potassium, because your potassium is mostly inside the cells. So similar concept here, you're bursting a bunch of cancer cells, and in those cancer cells, you have that potassium. So this is happening, um, occurs from rapid destruction of cancer cells, leading to hyperkalemia, hyperuricemia, so uremic acid, and it can cause you can cause acute kidney injuries. Does that make sense? Because we're releasing all these electrolyte stuff, especially potassium that your kidneys directly work with. And you will learn more about acute kidney injuries in 232. Don't worry about it too much for now. What you really just want to worry about is um, what to monitor and how to treat it, kind of having a basic understanding about it. Let's talk about treatment first. So if someone's having all this influx of stuff in these cells, how do we treat it? So one of your main things is going to be aggressive rehydration to flush out, to keep kidneys working, flush out, and flush out potassium and uric acid. What are some other things we can do to treat hyperkalemia? So you can do diuretics. So and diuretics. Also technically one of the ones for, but it's not your mainline one for hyperkalemia. So you have, yeah, someone mentioned, would you just give insulin by itself? Oh, there you go. Nice. You caught yourself too. Nice. Yeah, the kyaxalate. What else? If you guys remember this from 212. Yeah, if it's really bad, we can do dialysis. It's possible. There's some other ones that you can do, like calcium, I think calcium chloride or gluconate can cause the cells to go back in really quick. I think bicarb, yeah, bicarb is another one. Yeah, the C big kid. So that's pretty much all of them, right? C B I G K D. There we go. I believe the D that she gave us was like diuretics or dialysis, but it wouldn't be a first line for either. Um, you'd kind of go in this order, probably. Ones are temporary. This one, and this one can be very effective, but they're not as this one's not as quick. And this one obviously requires you to do a bunch of glucose checks and stuff. Okay. And then what about the for the hyperuricemia? There's like a specific met I think she mentioned. Yeah, allopurinol. Awesome. So, all right. So, what are some things we want to monitor then on this person? Since we're doing all of this stuff here, we're doing this stuff here. Yeah, I like that. Like that. FNE daily weights is a good thing to do with anything kidney function on your nose. Yeah, so kidney labs. So your BUN, creatinine. Creatinine's gonna be BUN, creatinine are gonna be important. Your GFR could be one. Isonos in general, yeah, for output and all that good stuff. So if they do have hyperkalemia, what's like another thing we want to be watching out for? So what does hyperkalemia potentially lead to? Yeah, so you can look at their EKG for this risk. Awesome. So that's pretty much that there. Any questions on this one? Does is hit increase the radiation due? Oh, is it increase the radiation? Could you rephrase the question? Increase the radiation.
I meant one of the treatment for this condition we were talking about, I forgot the name of it.
Uh-huh.
Uh, is increase radiation.
Let me see if I have anything on that here.
I think that's what was mentioned on the slides.
I don't have it on mine, but you might be thinking of spinal cord compression, the next one.
Maybe.
Because tumor lysis syndrome is pretty much just caused from going too hard on the therapy. And the spinal cord compression is like like a tumor causing compression. Same with the superior vena cava syndrome.
Got it. Thank you.
Yeah. But probably just double check your notes to see if 'cause I don't have it on mine. And then see if maybe when we talk about the next one, it feels more familiar on that one. But in the meantime, spinal cord compression. Let me see here. What is some of your signs, like your signs and symptoms that you're looking at, you're really thinking about? Kind of goes with that name. So you have, yeah, the pain, exactly. So specifically back pain, that's because it's compressing your spinal cord. Severe back pain, due to compression from a tumor. What else can you potentially have from here? This is your main one though. Yeah, you can have some issues with CMS, neuro, all that stuff there. But your CMS would be in your, especially your like your lower extremity CMS. But you can have muscle weakness, weakness slash paralysis, because you're pinching nerves and stuff. That's where a lot of that can come in. Yeah, urinary retention is one of them. I think your main thing is that you are compressing the back. It's causing CMS and neuromuscular issues. So that's why you gotta do a few things here. So some of the treatment kind of goes along with that and the pains. Gabapentin. I don't have that one on mine. I have a few other things on it for the spinal cord compression. kind of put that here is that's the CMS of lower extremities because the pinching can cause them to be um unable to feel or move or have proper perfusion to that area. Yeah, so you can get IV corticosteroids for the inflammation. So there's a tumor, it's causing compression. The corticosteroids can be good for decreasing the inflammation there. What else can you do? So we have this big tumor in the area. A lot of time this is due to like Mets, like metastasis, chemo. What's another one that's
Radiation. You
yeah,
could radiate it.
localized radiation to the area. So they have the spinal cord compression. We can put direct radiation to the area, try to make the make it go down, help with the pain, help with the fact that it's affecting nerves, pinching nerves, causing all these other stuff. It can even cause like difficulty breathing and stuff. But all of these um mm, obviously this is something that requires immediate attention, but it's something that's compressing your spinal cord. Yeah, so yeah, vena cava and then also your spinal cord compression and have the radiation. That's kind of a spoiler alert on this one. Yeah, but we're really focusing on the comfort here. When if I think I believe when it does get to the point where you are having spinal cord compression, their prognosis isn't particularly good. Kind of has to go with the metastasis and all this other stuff. Okay. So now the superior vena cava syndrome. What do you guys know about it? Essentially, yeah. Basically, you have a blockage, likely from a tumor or whatever, tumors, clots, whatever, but it's usually like tumors. In this scenario, prevents the blood flow from the superior vena cava to the right atrium. So you're going to have a backup of fluid leading to edema in that general area. So you're going to have edema in chest, a neck, which is definitely pretty bad because you if you have that, think about like the thing we talked about when you can have the inflammation of the neck from the radiation, localized radiation, it can lead to airway issues. So these people can have issues with their airway, it can be painful, pain, airway. So that's a very key thing here. Yeah, I'm sure they can if they do have airway issues, Strider is one of your if you hear that, you immediately gotta do something about it. Try to see if you can get more hands on deck. That means that there is a severe blockage and they are not able to really breathe properly. And so now this one, how is this treated? Kind of already talked about it, but other than because we did already talk about it, it's the high doses of radiation, and this is usually like a palliative care. Patient is not really going to make it too much longer once they have this condition happening. It's really for comfort. Try to make that swelling go down. Some other things that can also be caused by the cause and blockage and stuff like that. They can have decreased cardiac output because obviously we're preventing blood from making it through. That can lead to altered level of consciousness, um, hypertension because there's a backup, and then your JBD. Remember that one? That engorgement of your jugular. Um, yeah, that's something you might be able to see on the person and obviously to really assess their airway. There's not hypotension. So I guess think about your patients with like heart failure. They'll typically have hypertension, even though they're having issues with backup of fluids going on. There is such thing as a cardiogenic shock, which can happen where you do have pump failure and not able to pump blood, and you have backup of fluids and both ends of your heart. But in this scenario, it leads to potential hypertension. Think about like your heart failure patients. Any questions on anything so far? We're almost done. The next two ones are pretty specific. So your hypercalcemia um, is a little bit more specific to cancers like leukemia or lymphoma. These are symptoms like hormonal release. So this one's caused by like parathyroid hormone, and your SIADH is also something that's caused by specifically like a lung cancer. So they're not as general as the other ones, which can happen to pretty much all of them. You can have it you can have all the other ones happen on more generalized, but these are a bit more specific. So hypercalcemia is exactly what it sounds like. It's a lot of calcium in the blood. So I'll write down hypercalcemia and release of parathyroid. For information that doesn't really matter. I think the main thing for this one is just kind of knowing your main treatment and maybe some signs and symptoms of hypercalcemia. You guys know it. Osteoclast. So that, yeah, so you will have increased osteoclast activity. So if you have increased osteoclast activity, that means you're having a breakdown of bone. And so that calcium from the bone is then existing in your blood. So that's where the hypercalcemia kind of comes in. So breakdown of bone. So if you have breakdown of blood, what can we expect? Yeah, you can have some nausea. Yeah, bone pain. Bone pain, bone fragility, more likely to get a fracture and stuff. Your calcium's also kind of involved with muscle movement, so you can have muscle weakness. And your calcium can also involve with your heart, so you might also have some dysrhythmias happening with some altered level of consciousness. And just in case you guys are asked, I'm gonna go and look up your two signs with hypercalcemia.
Osteoporosis.
If I can get one that this is one of the conditions, and you might have seen it on your Kaplan. Yeah, it's always on Kaplan, huh? So it's your Bostic sign, which is when you put a little bit of pressure on a specific part of your face where the nerves are, it causes your like a reflex to flinch. And then the other one is the Trousseau sign, which is when you put a blood pressure cuff on someone inflated, it will cause their arm to do gang signs. That's not the best picture. This is a great one, but it's want both at once. Have I ever done this to a patient? No, honestly, I think if anything, I see hypocalcemia more commonly in the hospital. Yeah. So yeah, here, here's again an explanation. The Fossex sign, phosphorus. What about phosphorus? Oh, what lowers calcium levels? So your calcium and your phosphorus have like that inverse relationship. So someone that has high phosphorus can get calcium to help with the phosphorus. So someone with like a kidney patient, for example, um can get calcium supplements, but also um calcium acetate as a phosphorus binder. So they eat it with, they take it with their food and it binds to the phosphorus. So it helps with the phosphorus buildup. Your albumin also has like a relationship with calcium. So your albumin will bind to your calcium and not necessarily inactivate it, but your blood draws will not actually pick up the calcium that is connected to the albumin. So so technically your serum calciums and your CBCs are inaccurate. And there's actually like a formula to get the correct calcium level, but it's extra information you don't need to know. I found out I didn't know about this until literally like a week or 2 weeks ago. I think 2 weeks ago. But yeah, your Fossack sign is tap the face just below and in front of the ear. If there's facial twitching occurs on one side, it's positive, meaning that hypercalcemia. And then Trousseau sign, place the blood pressure cuff, inflate it for a bit. And if you become Italian for a little bit, then it's also positive. So I'll throw that in here. And okay. So, and then for some treatments, yeah, you guys already mentioned calcitonin. That's a great one. So the way I think of it is calcitonin, calcitone, calcium in calcitone in the bones. So puts that calcium back in the bones about it. In addition to that, what else could we do? I think for this one, specifically also said some not diuretics per se, but something. So I'm gonna double check to see if that can help. Yeah, so specifically loop diuretics. But with your loop diuretics, you have to do something alongside of it, not just loop diuretics. Similar to the other one when you have influx of stuff. Yeah, you want to have aggressive hydration still. So you do want to have a lot of fluids alongside your loop diuretics to kind of flush it out without killing your kidneys. Because remember, your kidneys are going to need um to be perfused and it's going to need volume. So you don't want to make the kidney sad.
The kids.
And yeah, someone says bisphosphonate. Perfect. Bisphosphonate. So an example that I have, it's like a medication, Voniva. Bisphosphonate's also going to help with that. Someone said steroids, and I believe, yes, corticosteroids. Corticosteroids also will help with that. So your corticosteroids can waste some of your calcium and your potassiums. That's something you can do for that. Okay. Kind of what we're on about for this. And then lastly, your SI-ADH. Does anyone know what that is? This is something that's specifically caused by lung cancer. Your water. Be more specific, but you're on the right track.
Oh.
Exactly. Yeah, so you have too much ADH leading to retention of water. Are you holding water by itself or anything else alongside of it? And if so, how's it affecting? So are you holding electrolytes or are you just holding water? Yeah, so Giselle actually has it right here. It's only water. You don't hold on to electrolytes with ADH, just water. So it has a different mechanism. It's the ADH will tell your kidneys reabsorb more water. So what actually happens is that you are retaining only water. So you will actually have dilutional hyponatremia instead. Delusional. I meant dilutional. It might cause you to be delusional, but so a way to think about SI-ADH is you have SI ADH. So you have SI for soaked inside because you have so much fluids. And in 232, you'll learn of almost like the opposite condition, which is diabetes insipidus, which is not a real type of diabetes. It's just called that because it has similar symptoms where you're always peeing a lot. And that one's caused by the opposite, where you have not enough ADH. And then that one, diabetes insipidus is dry inside. So that's like a really cool, easy way to remember it. But for now, just know SI, soaked inside, because you are retaining water. Awesome. Because hyponatremia is good, so we can get rid of water. What do you mean by that?
I mean, since they have hyponatremia, that's good, right? So we can get rid of the water.
And how do you want to get rid of the water?
I mean, because water full of sodium, so we don't want too much sodium. So we give them like low diet on sodium with that, even though they have hyponatremia.
Let me turn you up. My thing's not turned up all the way. Can you say that again?
Yeah, do we give them like low sodium diet
Okay.
so we can get rid of the water even though they are hyponatremia?
Well, how do you want to get rid of the water? Is what I'm asking.
Diuretics,
So
not the diet.
typically you don't give diuretics, but let me double check with that from memory. Do you even have SIDH on?
That's third semester. They don't go over it that far.
Huh. Where's you guys even
It
go?
is
Oh, it
here.
is here. Okay, my
It's
bad. Making sure that I'm not trolling.
monitor labs,
Hmm.
ISOs,
Oh,
diuretics.
yeah, you guys were actually taught to do diuretics. We were taught to do more fluid restrictions when you in 232. That's interesting.
You know what? You got to give up your position as a tutor now to lead. Over.
I'm just trying to make sense of it.
Yeah. But basically the reason why I'm actually surprised that they put diuretics here is because you would be getting rid of mostly salt. So you diuretics will like your loop diuretics, your thiazides get rid of salt, and the water follows. So this could make you go really low into hyponatremia because you're essentially you have a lot of water, but you originally started with a normal amount of salt. So if you're doing diuretics, you're gonna be losing salt and water even if they're losing it at the same amount of time, you're still gonna have that consistent low sodium in your blood, which could lead to seizures and all this other problems. So that's why I surprised that diuretics. Because I would say fluid restrictions make a bit more sense. But I would say I'm not sure if it's in your slides or anything, because but if it is, I guess go with that. And if I don't know how much information was on your slides for that, but for sure there is some sort of there should be a fluid restriction.
I got it now. Thank you.
Yeah, but how are you guys taught on this one, if at all? Actually, go with whatever you were taught for this class. This is what I think makes sense. But
Says fluid restriction.
okay, it doesn't say diuretics in your slides. Making sure. Don't want to give you guys whatever they're not like something that they're teaching different for this class. Jennifer says it says fluid restrictions. Oh, okay. So did they not go over SI-ADH very much in lecture or slides? Without just being extra in my notes, and then I put the wrong treatment? That's crazy. And
Well, that was in 232. They told us we could do Lasix, but typically it's another type of diuretic that's used.
okay.
But we went extra.
Yeah.
That was extra.
Kaylin saying we went extra on our notes.
So no wiggle.
Yeah, I guess you guys don't go over too much on it. But just fluid restrictions can increase NA and just monitor sodium levels because hyponatremia lead to seizures, muscle weakness, all this other stuff. That's just something to watch out for. So I guess if you guys don't even go over it, I'm not gonna
Jennifer went in.
throw more into the wind because it's irrelevant for now.
I'm irrelevant.
I think the way I really organized, I think the way I organized applications was for I think is the most important. So I thought sepsis and DIC and tumor lysis syndrome were the most important ones. So and spinal cord compression. And then superior vena cava syndrome is just kind of like palliative care, radiation. The other two are a little bit more like these are just very specific forms of cancer. Um, yeah. So, yeah. Is there any questions or anything you guys want me to cover more on? If I maybe I skipped some things. Again, this is the QSEN and the best practice that we talked about earlier. I think that's looking through that's going to help a ton. And again, really understanding the pancytopenia and the photosensitivity with radiation, biopsies are number one. Anything else that anyone wants to know anything about? You have access to both me and Kaylin at the same time if you need anything.
It's insanity.
Over brachytherapy. Yeah, so I believe that's um
The
in,
internal.
internal, right?
That's the little pellet.
Little pellet.
Little pellet.
Sure. Let me see what I have on it. Do they have questions for us grading or stage types of cancer? I don't remember that, but I can't say for sure. But that's the reason why I didn't really go over it too hard is because I don't. If they were to test you on that, they would give you the scale. Like, they would give you this is how you interpret.
I have no idea.
But I don't remember it. I also cannot for sure say because I don't make the test and I don't know if they changed them. If they changed stuff.
I was gonna say we can't really technically say anything either.
Yeah. Math question. What did they test on?
Like dosage calc or something. I think.
I don't believe there's any math at all on any of the tests in 220. Maybe yeah, no, I don't think so. I'm gonna watch my words on that, but I don't
Yeah, they
believe.
can't use paper. They were told they can't use paper.
Okay. Well, even if you can't use paper, Exemplify has its own calculator, but I don't think there's any math questions. I don't even know what you would do math on for this dosage calcs, but I don't think Focus has ever been on. I don't believe so. Anything else? Oh, someone said questions on Brady therapy. I got it.
And you just left them behind.
I left them.
You
Yes.
left your own behind.
Yeah, nothing you really need to know too hard on. Like hyper specifically, just understanding Reiki is internal and teletherapy is external, and one of them requires your external requires isolation. Sorry, your external does not require isolation, and your internal requires reverse isolation. Your external is not radioactive, your internal is radioactive. I think more than that, I don't think there's anything else. I think once you have these two down, I think your focus kind of goes into
Well,
your best practice.
for Reiki therapy, was it like there was something within like if they have to you have to empty it out into the toilet a certain amount of times, like don't pick the pellet up off the floor either. Like don't touch the pellet. What they're trying to get at because it's radioactive. Like just know it's radioactive and don't do dumb things
Yeah.
with radioactive things.
Yeah, if you could hear Kaylin, I don't know if you could hear, but she said basically, you know, if someone has that radioactive seed and it falls or some like, it's like on the floor, don't pick it up. Be careful with it. It's radioactive. Be aware that that thing is radioactive. I think there might even be something here. Yeah, don't touch radioactive sorts with your bare hands. Just be careful. And Theron asked the seeds excrete themselves. I have no idea.
Wait, I'm unsure if I understand the question.
He says the seeds excrete themselves.
What do you mean excrete themselves?
I don't know. I don't know. Like they come off on their own.
Can you rephrase your question, please? Sorry.
Is Rosemary in here? Does she know?
I'm in here, but I don't really deal with radiation, but I just know that they use it for like liver and they target it right there. I didn't know if it discrete or it absorbs. I'm not sure.
Oh, okay. Theron says there was a question in the Iggy Book of Question. Iggy Book of Question.
There's like a study guide one.
Oh, in your study guide one. Oh, that one.
Yeah.
Study guide ones.
If I'm understanding the question like correctly, so the seed's placed up there and it secretes the radiation stuff. But I'm not sure reading that too, like, will the stool be radioactive?
Can I even hear you?
No, thinking about that, will the stool be radioactive? I think the person in whole becomes radioactive, hence why they tell you if someone has like brachytherapy implanted, that you have to be careful with their urine. I'm assuming that goes for stool as well.
Wait, so I think I remember the question. It said like once it's in place, are they gonna have to have another procedure to take it out? I think that's kind of what I meant.
Oh,
That Oh, okay.
That's a good
That
question.
is a good question.
I think it depends on how it was implanted. Like, if it was placed into some kind of cavity for whatever reason, then I suppose you can just pop it out. But if it's surgically inserted, then it makes sense that they would have to be surgically removed as well.
According to Google and
Google, Dr. Google.
Mr. Google, it's saying that at some point they become inactive, but um, they actually stay in place permanently. So they're not even removed. According to this Google is saying they do not excrete themselves, and they're not removed. They're just left in place even after they become inactive.
Oh, that's so weird. Bye.
Let me just double check that. Again, extra info you don't need to know. I can assure you you don't need to know that.
That's extra Miss Squirrel.
Yeah, it says here the seeds are not usually surgically removed. They're just kind of left there. And then they eventually become inert because once they deliver their dose, they stop really doing anything. But you can remove them if there's complications, but it's not typical. All right. Anything else that I can answer or Kaylin can answer?
Diego, are they gonna have, we gonna have to do the ABGs, like solve them?
I think at most, I think it'd probably be interpretation. Did you guys have an interpretation one in the respiratory anemia one?
Yeah, I think so.
Yeah, I think at most it's like here's an ABG. How do you interpret it? I don't think
Okay,
I don't think it goes very deep on it.
thank you.
Yeah. Yeah. As always, just let me know how the midterm goes. I'll find out, I guess, during the skills lab.
I heard good things about the hypertension CAD one,
Yeah, it seems like you guys did really good on the hypertension one.
but how did that make you feel?
It's good. Yeah. And
Yes,
hopefully this.
we appreciate all your help because that helped us a lot. Well, I can speak for me. It was very helpful.
That's great. That's great to hear. It was a really nice feeling. Let me stop sharing then, and then I'll give you guys the or whatever it's called, the Google Doc.
More power!
And then, um, once this is done, I'll try to get both the Kalen session and my session uploaded to the YouTube
Oh
channel.
yeah, 'cause I don't know how to do that.
I'll start thing and I'll post it. There we go.
Oncology.
Yeah, I hope you guys have um a good midterm. Don't get tricked by some of the weird questions. Just read everything,
Good breath. Compress.
decompress.
Do your box breathing or purse lift, whatever makes you feel happy. It'll be okay.
Right. I think with that we're good unless you guys have any other questions.
Thank you very much, Diego and Kimin.
Yeah. Good luck on your guys' test.
Best of luck. With the way that they were answering the questions, I don't think they need luck. They got it. They'll be fine.
Yeah, Kaylin says you guys got it. So uh you gotta you say
What are you trying to say? Jackie
Jackie's I
always
still need
believes.
You gotta show up.
Throw up gang signs
Yeah.
for the, what is it?
You gotta throw up
The
gang signs.
Tritao.
Yeah, trousseau. It's either gang signs or like you're doing the
Become Italian.
or you become Italian, but sometimes it's the same thing.
You say trousseau. Sometimes it's the same thing. Just hit me what you said.
Right. Adrian, you got any questions? I'll sleep on the wheel.
Bruh.
Let me stop recording.